Okay, we will start. It's time to begin. Um, just a nice reminder to everybody to shut down the mic, just not to interfere with the conference. And I'm very pleased and happy to welcome everyone to this first webinar. I want to thank every participant to this webinar who have joined us today. It's a first series of webinar dedicated to endometriosis, organized by the FHU Frame, which is a consortium who has been dedicated to endometriosis and will plan to make every year a series of webinar to international people to talk about endometriosis. First of all, I want to introduce the FHU Frame and this consortium who tried to bring together all the different departments of gynecology and obstetric of the APHP and the Hôpital Saint-Joseph. And we have the objective to promote the development of clinical research and collaboration between different teams to improve knowledge and education in the field of endometriosis. This year we are launching a series of three webinars dedicated to the modern diagnosis of endometriosis. And today is this session is the first of this series. So today webinar focus on the endometriosis diagnosis and about this clinical aspect and biomarker. And in the next webinar in September, we will talk about imaging. So I really want to warmly thank all the speakers who have agreed to participate to this webinar. We will begin with Professor Marguerite from Limoges, who will address the clinical aspect of endometriosis diagnosis. He make a thesis about the clinical marker of the diagnosis of endometriosis. Then we will hear the Dr. Chloé Ménien from Cochin Hospital from Port-Royal, who will speak about pain and infertility in endometriosis. Next, we will listen Johan Dabi from Hôpital Tenon, who will present the current guideline for the diagnosis of endometriosis. I want to warmly thank the Professor Charles Chaperon from Cochin, who will then discuss the non-surgical diagnosis of and the place of the laparoscopy in the management of endometriosis. And we know that it's a very hard work he did about the place of the surgery and the non-surgery attitude for the diagnosis of endometriosis. And finally, we will close the session with Dr. Ludivine Dorido, who is a researcher in the Institut Cochin and who will present the role of the current and the emerging biomarker in the diagnosis of endometriosis. So the webinar will conclude at the end with an open exchange with all the audience and the discussion with all the speakers for some couple of minutes. So again, I want to thank everyone to participate to the webinar, and I want to make a special thanks to Mrs. Rimli, who is the project manager, and the Professor Santouli, who is the head of the Department of Reproduction Medicine in our service, who participate to the organization of this webinar. So thank you everybody and welcome to this webinar. And we will start with François Marguerite for the clinical marker of the diagnosis of endometriosis.
Alors, je le remets tout de suite.
Good morning, everybody. I would like, first of all, to apologize for not being here on live. And I would like also to thank Professor Santoulier and Professor Marcellin for the organization of this webinar. Dr. François Marguerite, and I will be talking to you about epidemiology and diagnostic in endometriosis and I always begin my presentation with these two pictures. It is about detection of endometriosis because there is a difference between prevalence and symptoms. In the left area, you see the prevalence of endometriosis diagnosis in France. As you can see, there is a high prevalence near the age of 40 years old. But the thing is that you have symptoms which are not correlated with the prevalence. As you can see on the right side, which are symptoms driven from the Constance cohort, you can see that the prevalence is higher in women of young adulthood. When you are going to the 40 years old, as you can see, the prevalence of dysmenorrhea are at the lowest rates. The thing is, when you look for young women, you have a very low prevalence of endometriosis, which are detected, and a very high symptoms, which means there is a difference between the symptoms that are presenting in the woman and the disease, which couldn't be or maybe is underdiagnosed at this age. So what it is said about endometriosis? It's a disease that may concern 1 woman among 10 women. So which means it represents worldwide more than 190,000 women and among 1.5 million of women worldwide. It's just more than other diseases that we already know, like hypertensive disorders or like diabetes. Be careful with this kind of data because it's a global prevalence, which doesn't signify that all the women with endometriosis are symptomatic or need to be treated. So, as I was saying later, the thing is we have to know the history of the disease in order to have the data about prevalence and incidence. And the thing is, we are not knowing sufficiently how the disease will come and how the disease will end. The thing is, we all know that the disease begins with chronic pain-based symptoms, such as dysmenorrhea, and then the symptoms are growing, and we don't know if the lesions are coming afterwards or if they are still existing in the beginning. And there is an issue here because there is a difference sometimes with symptoms and the lesions which are coming, which make it difficult also the diagnosis of endometriosis and also all the hypotheses about physiopathology. But I think there will be other presentations that are dealing with this kind of topics. So we are going into the subject about the prevalence and what are the data that are available in the literature. Fortunately, we have a recent meta-analysis which are giving us some recent data. And as you will know, there is many sources of data. There is data that are self-reported, there are population-based integrated information systems, which means they are coming into the economic database and giving some prevalence. And we have also data about cohort studies. And we'll see it will depend on the sample, the age of the population of reference, and also about the country, so how you are making the diagnosis or not. And also the source of diagnosis and the mode of detection are just giving prevalence that are ranging from the simple or to the double. what are the results of this meta-analysis? About the prevalence, it's between 1 and 8%, which means it's varying from 1 to 10 times higher. As you can see, self-reported data are at 5%, population-based integration system 1%, and other source of data 4%, which means most of the time you can heard then it is 10% of the total population, but I always insist that it is 10% about the whole population, which means it's varying during the age and during the population of reference, which means you can't say every time that it's 10%. I prefer that it's between 1 and 10%. About the incidence, it's also varying from 0.45 up to 3.90 per 1,000 person year, which means it's varying from 1 to 36 per 1,000 person year up to 3.53 per 1,000 person year. As you can see, it's different estimation coming from different databases, which means we don't very know, we don't know what are the true incidence. We just have a range that is ranging from 1% up to 10%. When you look at the figure of this meta-analysis about prevalence and incidence, as you can see, there is some data which are in a range coming from very low prevalence up to high prevalence here, and you have in the middle the overall prevalence, and there is the same for the estimation of the incidence. The problem with this kind of estimation is this kind of things, heterogeneity, which is very high. The y square is calculated around 90%, which means all the estimation are not the same within all study, which means you have this kind of data, but you have to give them with some cautious because of this heterogeneity. So also, there is some geographic insight, and sorry, I have just data about France, which are coming from the study of Lemoyle et al., which estimate incidence of endometriosis from the Insurance National Database, which is SNDS. And they estimate the relative risk of being diagnosed with endometriosis within some areas of France. As you can see, it is very different in which area you are, and there is some geographic insight and geographic disparities with the diagnosis of endometriosis. I think it will be kind of the same in other countries and also in other European countries. So what about time to diagnosis? We have also a literature review and with some estimation. The problem is which criteria do we have? You can have the time between the onset of the first symptoms until the diagnosis of endometriosis is made by a physician. It is the overall diagnosis time, but as you know, you don't have all the data available, and sometimes you take the time between the onset of first symptoms until the first related physician visit. It's the time between the first symptoms until a woman is coming to the doctor. And you have also a third definition, which will be the time between the first physician visit and diagnosis of endometriosis. So, what are the data? As you can see, there is a very wide range between the diagnoses that are made in other countries, but most of the time it's near 5 up to 12 years of diagnosis. As you can see, it can range just under 1 year between the first clinical diagnosis time up to 12 years from some estimation in France. So what I will propose you, it's another approach, and these are my works, and I just focus on how can we diagnose endometriosis coming from also national database. What do we have right now, and what I have presented in the last slide, it was only declarative data, which means how much time from first symptoms up to hospital diagnosis. And what we know, it's between 7 to 10 years or sometimes more than 12 years. And the problem is we don't know if endometriosis is under or overestimated. I present you on the right side of the slide another estimation about adolescents with pelvic pain, and as you can see, you have the prevalence ranging from 100% and which is going to less than 30%, which means you don't know where the prevalence is, and it will depend on the population of reference you take. So my new insight is that I focus on what happens before diagnosis. Before diagnosis, we know that women are just asking for some medical advice, which means a consultation in a general practitioner, pediatrician, gynecologist, midwife, and there also requires medication with hormonal treatment and painkillers, and also radiological examination, pelvic radiological examination, ultrasound, and MRI. So what are our hypotheses to estimate the clinical diagnosis time from first symptoms up to diagnosis? We focus on young women, and we made the hypothesis that in young women, maybe endometriosis is under or misdiagnosed. And we would like to estimate time from first symptoms up to the diagnosis, which means we have to know the pathway here before diagnosis. So what happens before diagnosis? We all know that the first symptoms are beginning with dysmenorrhea, and after dyspareunia and other chronic pelvic pains or non-menstrual chronic pelvic pains are coming afterwards. Most of the time, the imaging is often used like pelvic ultrasound and pelvic MRI for severe pain, and there is most of the time first-line treatment delivered like hormonal therapy and painkillers, which means we have a care timeline from first medical visits up to a prescription and up to imaging, which means we need to have a virtual nested cohort based in a national data, and we have it in France. The estimation we have made is coming from the national insurance system, which means we have estimated all new diagnoses coming from 2018 up to 2021 using the ICD code N80.X. And we focus on the consumption of care 10 years before, and we focus on the medical consultation, medication, and pelvic radiological examination. And we estimate that the first times of symptoms will be when 2 of the 3 events are present are just occurring in the range time of 6 months. So the first occurring of these events in the last 10 years will be the beginning of the symptoms. And afterwards, we were able to estimate the time interval from first symptoms up to first hospital diagnosis. So in France, we have 9,088 new cases of endometriosis. And as you know, the incidence is also growing, and with the prevalence of new cases of 0.3%. As you can see, the forms of endometriosis are different, and most of them are peritoneal forms, which means minor forms. And the global median times from first symptoms to diagnosis was calculated at 9 years. It means it's an estimation based on objective data. And as you can see, the median time is not varying so much with age at the diagnosis varying from 8.4 years up to 9.3 years. If you are searching for a difference, it's statistically different, but as you can see, it's not very clinically different. At the same time, it's the same thing for the type of endometriosis, which is varying just around 9 years median time of diagnosis. And there is a role of radiological examination, which can varying with the time from first symptoms up to the diagnosis. As you can see, it is a variation between the delay to diagnosis and the time to the first MRI and to the first ultrasound. To the first ultrasound, as you can see, there is a much prescription in the first year, but which is not coming with a diagnosis of endometriosis. But with the time to the first MRI, as you can see, the longer is the time to the first MRI and the longer the delay to the diagnosis here, which means maybe there is an insight with the prescription of the first pelvic MRI. So what are my conclusions here? It means that the prevalence, which is ranging from 1 to 10%, varies with age and also with what kind of identification you take. The history of the disease is not sufficiently known to have sufficient objective data about the disease. And I think there is a role of clinical examination, but there is more presentation coming which are giving you much more data. And what do we know is that there is a very high consumption of care before the diagnosis, and maybe we need to focus on this kind of consumption of care. And rather than the disease, as I said in the beginning, maybe the treat first symptoms are the first light events. So this is the end of my presentation. Thank you very much for listening to me. I give you my email address in case if you have some question, and I hope I will be seeing you soon in Limoges City. Thank you very much.
Okay, because it was a recorded presentation, we will not be able to have any question for Professor Marguerite because he was not available at this time. But we will move now to the next speaker, who is Dr. Chloé Ménien. I want to thank her very heartily for her participation to this webinar. Thank you very much, Chloé.
Thank you, Louis. I hope you all hear me well and see my slides. Good evening, everyone. And I also want to thank Professor Marcellin and Santouli for trusting me in doing this lecture. So, pain and infertility are the two hallmarks.
Chloé, on t'entend pas.
Ah, ok.
Moi, je t'entends.
Ah. Donc,
the sound is perfect. It's work.
Okay, so I go on. So pain and infertility are the two hallmark manifestations of both endometriosis and adenomyosis, and very often they coexist. And this is where management becomes challenging because the treatments that relieve symptoms are not necessarily the treatments that optimize fertility. Hormonal suppression, for instance, controls pain, but is contraceptive. Assisted reproductive technology is the main therapeutic option for infertility, but it does not directly affect the disease. And surgery may relieve pain, but can impair ovarian reserve and alter ART outcomes. So how do we balance these objectives? My aim today is to show you how pain symptoms and infertility should not be considered separately. Their characteristics, their relationship with disease phenotype, and their prognostic value can also help us personalize fertility management and IVF protocols. And to answer this question, let's first look at pain. Pain is the most common clinical manifestation of endometriosis. In a recent large French survey conducted among women with endometriosis under the auspices of Gedeon Richter Laboratory, between 60 to 80% of patients reported chronic pelvic pain. And this pain results from a complex interplay between inflammation, neurogenesis, and central sensitization. And this creates a self-sustaining pain cycle. Importantly, many patients also present with overlapping pain syndromes such as irritable bowel syndrome or interstitial cystitis, which may further amplify symptoms through cross-sensitization mechanisms. Clinically, pain diagnosis is mainly based on a careful history. The key symptoms you need to assess are dysmenorrhea, deep dyspareunia, non-cyclic pelvic pain, dysuria, and dyschezia. But beyond the type of pain, three characteristics are particularly suggestive of endometriosis. First, the intensity. Pain is often severe with pain scores above 7. Second, the timing. Symptoms are typically cyclic with a clear menstrual exacerbation. And third, the patient profile. Pain often begins early, sometimes during adolescence, and has a major impact on quality of life, including school or work absenteeism. And finally, response to continuous hormonal suppression is also informative. If pain improves under amenorrhea, it supports the clinical suspicion of endometriosis. Once these symptoms have been identified, the next step is to ask whether the pain profile can help us predict the anatomical location of the disease. An important point is that superficial endometriosis should not be considered a clinically mild disease. Despite its limited anatomical extent, it can be highly symptomatic, particularly with severe dysmenorrhea. On the contrary, endometriomas are usually associated with mild to moderate pain. Therefore, when an endometrioma is associated with severe pain, we should suspect additional deep infiltrating endometriosis. For deep lesions, certain symptoms may suggest specific locations. Dyschezia and dyspareunia for posterior deep endometriosis, dysuria for bladder involvement, and severe dysmenorrhea for adenomyosis. So pain symptoms are highly informative for clinical diagnosis, but they do not fully and always correlate with disease severity. Let's now move to the second major clinical manifestation, infertility. Approximately 20 to 30% of patients in endometriosis population experience infertility. The mechanisms are multifactorial. Peritoneal inflammation impeding gamete interaction, tubal dysfunction, ovarian reserve alterations, adenomyosis-related uterine dysfunction, and even reduced sexual intercourse due to dyspareunia. And unlike pain symptoms, which may provide clues regarding disease location, the relationship between endometriosis phenotype and infertility appears much less straightforward. For instance, superficial endometriosis, despite being considered the mildest phenotype anatomically, is associated with a significantly increased risk of infertility, with an odds ratio of 1.5 and a higher risk of miscarriage compared with controls. Conversely, endometrioma seems to have a more limited impact than commonly assumed. They do not impair spontaneous ovulation of the affected ovary and are not independently associated with infertility after adjusting for confounding factors in our clinical experience. Similarly, even in deep infiltrating phenotypes, spontaneous conception is possible with live birth rates approaching 50% in some cohorts managed without systematic surgery. In contrast, adenomyosis appears to be a genuine fertility factor. In our cohort, approximately 30% of women with adenomyosis presented with infertility, and external focal adenomyosis was associated with almost a twofold increase in the risk of primary infertility. And among all these phenotypes, ovarian endometrioma are often the greatest concern for fertility specialists because they directly involve the ovary. Many clinicians assume that they severely impair ovarian function, but is this really the case? Let's first look at oocyte quality. And we can look at it through the IVF model. Available data are very reassuring. In the study by Junot and colleagues, displayed in the left side of the slide, including more than 300 women with endometriosis undergoing pre-genetic testing of aneuploidy in IVF cycles, the embryo aneuploidy rates were comparable to those observed in controls across all age groups. And these findings are further supported by data from the British ART registry, displayed on the right side of the slide. Live birth rates were similar in women with endometriosis using oocytes and in recipients of donor oocytes, suggesting that oocyte competence is largely preserved. But if oocyte quality is preserved, the next question is whether endometriomas affect ovarian reserve, egg quantity. And this ovarian reserve may be slightly reduced in endometrioma patients. Meta-analysis show lower AMH level and fewer oocytes retrieved in endometrioma patients, but the main negative impact comes from surgery rather than the disease itself. So this reinforces the idea that we should avoid unnecessary surgery. And another important question, if ovarian function is preserved in endometriosis, what really determines IVF prognosis, fertility prognosis in these patients? One might think that more severe endometriosis would lead to poor IVF outcomes. However, our data suggest otherwise. In more than 350 women undergoing more than 700 IVF cycles, neither the anatomical phenotype nor pain severity affected implantation, clinical pregnancy, or live birth rates. In other words, neither the disease extent nor the symptom burden predicts IVF success. So, what's the key prognostic factor? This is where adenomyosis emerges as a major determinant of reproductive outcomes. In our cohort, endometriosis women with associated adenomyosis had significantly lower cumulative live birth rates after IVF than women without associated adenomyosis, as you can see in the left side of the slide. And this finding is consistent with several meta-analyses showing lower pregnancy and live birth rates together with increased miscarriage rates in adenomyosis patients. But not all adenomyosis are equal, and prognosis probably varies according to phenotype. Enlarged uterine volume and diffuse internal adenomyosis seem to carry the poorest prognosis. At the beginning of the lecture, I mentioned that pain and infertility should not be considered separate. We have seen that pain severity is not a prognostic factor for IVF, whereas adenomyosis is, and this has important implications for clinical management. In women presenting with both infertility and pain, surgery should not be performed systematically, simply because symptoms are severe. However, we should not ignore pain. So the challenge is to address symptoms while preserving fertility potential. And this is where we can optimize IVF protocol. So rapidly, I will finish on this. The first strategy to manage painful infertile endometriosis patient could be to use prolonged hormonal suppression before IVF. Several studies have shown that pre-treatment with oral contraceptives or a GnRH agonist can significantly reduce pain scores in women with endometriosis and adenomyosis. So this may help improve quality of life while patients are waiting for fertility treatment. A second strategy is the use of GnRH agonist triggering instead of conventional HCG for ovulation triggering. GnRH agonist triggering has been associated with lower post-retrieval pain scores and less severe dysmenorrhea in women with endometriosis, as shown here in purple bars. And this is primarily aimed at controlling pain symptom. However, in severe adenomyosis, this protocol adaptation may also offer an additional advantage as it may perhaps improve implantation and reproductive outcomes. For instance, freeze-all strategies, usually following GnRH agonist triggering, avoid exposure of the endometrium to high estradiol levels linked with ovarian hyperstimulation. And this hyperestrogenism may be particularly detrimental for uterine receptivity in adenomyosis patients. So freeze-all seems to perform well in such severe adenomyosis patient. Moreover, several observational studies suggest that combining this freeze-all strategy with prolonged GnRH agonist suppression may provide the best reproductive outcomes, as shown by a study by Vu and colleagues here on the right side of the slide. But these data remain observational. So to conclude, pain and infertility should not be viewed as separate entities. In symptomatic patients, medical treatment may help control pain and bleeding before fertility. Surgery should be reserved for selected cases, particularly after failure of medical management. In contrast, asymptomatic infertile patients can usually proceed directly to conventional IVF. And finally, when medical treatment succeeds, or in case of IVF failure or severe adenomyosis, we can adapt IVF protocols using strategies such as freeze-all and GnRH agonist pretreatment. Ultimately, the goal is to integrate both symptom control and reproductive prognosis into a personalized fertility management strategy. Thank you.
Thank you very much, Chloe, for this crystal clear presentation again, and the quality of the data you present. Very warm thank you for participating to this webinar. It's a very a complex question to address both the pain and fertility in the management of endometriosis. So thank you very much. It's a very nice presentation as usual. So again, thank you. We will move to Johan Dabi now, who will talk about the international recommendation about the diagnosis of endometriosis. And I want to thank very warmly Johan to participate to this webinar. I hope you can share your presentation.
Yes, I'm
Thank
trying
you,
to.
Johan. And the screen is yours, how we said.
Well, thank you very much for inviting me. I'm very happy to present you today's HAS and ESHRE guidelines for diagnosing endometriosis. So we will focus on the imaging exam, and then Professor Chaperon is going to talk to you about the laparoscopy and the non-invasive diagnostic test currently available. Or not. So let me share you full screen. Is it okay for you?
It's perfect.
Okay. So my objective today are to decode HAS and ESHRE diagnostic frameworks, to review how pelvic examination can contribute to positive diagnostic and how is it complementary to the ultrasound and MRI performed by the radiologist, and how it remains fundamental to keep the pelvic examination in the diagnostic frameworks for the patients. Well, there is really few differences between the HAS and ESHRE guideline, but we can talk about it. And then present you the latest ESHRE consensus on MRI standardization, because I think it's important that all the physicians and the radiologists talk about the same thing when they talk about endometriosis. So I'm going to skip this part since I'm not the first one to talk, but you know that most patients with endometriosis, even sometimes with severe and extensive lesions, have normal physical exam. And Dr. Mignon has talked about the three subtypes of the disease. Basically, over the past few years, there was a paradigm shift where laparoscopy was absolutely the gold standard for diagnosing patients, and there was a lot of patients undergoing unnecessary invasive procedures just to get a diagnostic. But thanks to the improvement in the ultrasound and MRI techniques, as well as our comprehension of the disease, it's no longer needed. And currently, first-line imaging remain for us ultrasound. And we're going to see that the ESHRE guidelines enables to do an MRI as a first-line imaging exam in patients with suspected endometriosis. Symptom recognition is determinant, because if the physician does not evoke the diagnostic, it will not lead to imaging exam. And both guidelines agree that severe dysmenorrhea, which is the main symptoms in this patient, is a sign that should prompt imaging exam. But you can have very specific symptoms that it's important to notice, because if you specific these symptoms on your prescription for the imaging exams, the radiologist will know what to look for sometimes. For example, if a patient have a pain in the shoulder, right shoulder, during the menstruation, it's important to notice, so the physician can look for peritoneal endometriosis in the diaphragm. So that's the kind of stuff that's important to note when you see patients in consultation, to help the radiologist and specify the patient's symptoms to help him give you the best reports he can do based on these intels. Another situation is obviously the situation of infertility that Dr. Mignon talked to you about. And in patients with unexplained infertility and chronic pelvic pain, endometriosis is always a diagnostic that you should mention. Learning to do physical examination in patients with endometriosis take a few consultations, but it's a determinant step towards the diagnostic for the patients. When you start examining patient with endometriosis, sometimes you're not sure what you should look for and how you could positively assess the presence of a lesion. But the more you will examine patients, the more relevant your physical examination will be. So that's the first thing to matter. Another important thing is that physical examination can help you assess differential diagnostic, such as myofascial syndrome, and also assess how important pain sensitization is in patients, especially with chronic forms of pain. So physician should keep examining the patient. it is also more important that most patients have a moderate or very limited extension of their lesions in the torus or heterosacral ligament, and we're going to talk about it. But in these locations, the imaging exam can sometimes be either inconclusive or discordant, so it's important for the patient that the physical examination can help sometimes assess the diagnostic. So I told you first line imaging remains a transvaginal ultrasound. And as you can see on the right, the performance of ultrasound is variable across the localization of the disease. Another important thing is to note that obviously ultrasound is really operator and center dependent. And when you ask for ultrasound, it's important to keep them in mind, especially when the ultrasound come back to you negative. So you have your physical exam to help you, and then the ultrasound reports. And I just wanted to talk to you about the main localization that, on my point of view, poses a diagnostic challenge, which is isolated torus or heterosacral ligament. So this chart was published in the HAS 2017. And as you can see, the sensitivity for diagnosing ultrasound localization of endometriosis vary from 5% to 88%. So really it's a wide range with sometimes very low sensitivity and sometimes quite good, but the specificity is pretty high, which means two things. First is that all these studies have been conducted in expert centers. We have really little data regarding the performance of ultrasound or either sometimes MRI in general practice. So that's the first thing. Second thing is that when reports of ultrasound specifically mention ultrasound localization of endometriosis, most of the time it's relevant. It means that the radiologist have looked for the signs and has positively assessed the presence of endometriosis. Second line imaging is MRI, which is also presented as a first line option in the ESHRE guidelines. MRI indications in France at the time remains the inconclusive exams of ultrasound in symptomatic patients. So that's one case. Second case is obviously pre-surgical mapping at any operative candidate and in patients resistant to medical treatment or not eligible to ultrasound because they have severe pain or vaginism or still virgin. Today, the preferred classification is DPEI, which was established and validated by Professor Thomasin Lagara, and I'm going to present you just after this slide. The important thing is that this classification enable systematization of the reports for the radiologist. So it's obviously improves always the communication between the radiologist and the surgeon in patients that will undergo surgery. And we know that sometimes some anatomical spaces can be we can talk about different things between the radiologist and the gynecologist, for example, the parameter or the distal part of the heterosacral ligament. So the main goal of this classification is to help make sure that we talk about the same thing, and this classification has also shown relevance to predict operating time in patients undergoing surgery, but also postoperative complications and length of hospital stay. So that's a really useful classification, and it really provides much more clarity for patient counseling in consultation. So the DPOE is based on the segmentation of the pelvic in 9 spaces plus 1 extra pelvic compartment, and then you get a score. If you have a score inferior to 2, you have mild endometriosis. You are moderate if you have 3 or 4, and you have severe if you have 5 or more. And in patients with severe endometriosis, the classification has enabled us to predict higher rates of complication when these patients are operating on. So another important thing on the latest consensus published was that it encouraged the radiologists to perform drawing. So now in Tenon Hospital, all patients undergoing MRI come out of the exam with a draw that make it clearer for them where the lesions are and how all the localization of the disease interacts with the organs. And it also enables a more easier communication between the surgeon and the patients. I take again the example of the uterosacral ligament because besides the consensus on the protocol, there was also a lexicon published to make sure that every radiologist talk about the same thing, and we know that a lot of patients sometimes come out of their MRI with a diagnostic or a suspicion of endometriosis based simply on a thickening of the uterosacral ligament. But as you can see, this latest consensus has gave a clear definition to talk about sickness or uterosacral ligament disease. So it's important because the main objective is that if the radiologist talk about endometriosis, he is sure that there is a lesion. It's not just a suspicion or just a sickness that most of the time is not endometriosis, and that's a really important issue for the diagnostic pathway of the patient. So just wanted to talk about this review published in 2022, but still to date was published by Pascual in Ultrasound. It's interesting because it's has synthesized all the performance of the different tools to diagnostic endometriosis, the clinical history, physical examination, ultrasound, pelvic MRI, and obviously laparoscopy that I'm not going to talk to you today. So I strongly encourage you to read this review. But what's important in this review is that Pascual advocates for a multi-pronged approach based on clinical assessments and ultrasound and MRI and then laparoscopy. And most of the time, especially in patients with mild disease, you have to do through all these steps to have a definitive diagnostic. So this is the diagnostic algorithm as published. So on the left, it's the ESHRE algorithm. So clinical vaginal examination remains important, and then imaging, ultrasound or MRI. And then it's pretty the same as in the HAS. Either you have positive signs of endometriosis, and then you have to precisely assess the localization and the disease, and then you can treat the patient. Or you don't have any clear signs, and you can go through empirical medical treatments, and then look for more specific examination in patient not responding, and that's the position sometimes of the diagnostic laparoscopy. In France, that's also the same thing with the HAS guidelines. It's just that we position the MRI in patients that are not responding to medical treatment, especially hormonal therapy, or in patients with infertility and chronic pelvic pain, because obviously in this patient you do not want to give them hormonal treatment. So when to refer a patient for specialist center management, and we can maybe talk on this point a little bit later. It's important that you refer patients with difficult diagnostic cases, and we will maybe see how laparoscopy or the salivary test can help in these situations. In patients with multifocal lesions, in patients with severe disease involving the ureter or responsible for organ failure, and in patients with infertility and complex endometriosis, of course. Just a small word before conclusion on patients with infertility and endometriosis. It's important that these patients are referred to early to specialists, especially the physician responsible for medical assisted reproduction. And this patient should undergo the whole fertility checkup and obviously the imaging exam to precisely assess the lesion on endometriosis. And it's another discussion, but in these patients, sometimes surgery can be also an option to improve the fertility rates. And a word on empirical medical treatment, because it's the way most patients are eventually diagnosed, because they have merely no lesions on imaging exam, and they are most of the time proposed with hormonal treatment. And in a lot of situations, they respond to hormonal treatment and they do not have definitive diagnostic. And most of the time, it's not important because they have merely no lesions. But in some situations, it poses a problem of having a definitive diagnostic, and sometimes the patient also asks for it. Just a small one, and maybe it will full the discussion with Professor Chaperon after his presentations. Currently, there is no evidence that early versus late diagnostic actually improve quality of life in patients with endometriosis, but a lot of patients, especially those with a lot of pain with ongoing for a lot of time, are requesting to have a definitive diagnostic, so that's important for them, but we can talk about it. So key message, maybe imaging first, diagnostic, and you should look for ultrasound and MRI in patients with no lesions or inconclusive exam, but positive symptoms and or physical examinations. Physical examination is important, and whenever possible, it's still recommended as a first step toward diagnostic for these patients. All radiologists, and we should encourage our radiologists to use the MRI standardization protocol and lexicon proposed by Professor Thomasin and Nagara and adopted at the European scale. Central sensitivation is important to be diagnosed by physical examination, and most important thing in a patient with complex disease or difficulty to achieve a diagnostic, these patients should be referred to expert teams. Thank you very much.
Thank you very much, Johan, for your very nice presentation and addressing all these questions about the guidelines and more than the non-surgical diagnosis and the place of the imaging. And we understand that the DPI now is becoming the standard of the organization of the description of the lesions that will be more helpful for all practitioners. So thank you very much. I don't know if you can stay until the end of the webinar,
Yes.
because I understood that you move, but we will continue to the webinar, and it's my we now give the floor to someone who has been at the origin of this paradigm shift in the diagnosis of the modern management of endometriosis. Someone who has truly revolutionized, maybe worldwide, the entire approach of the disease, and it's a great honor to welcome the one who trained all of us, Professor Chaperon, and I really warmly thank him to participate to this webinar. Thank you very much.
It's okay, Louis, you hear me?
It's perfect.
Thank you very much for inviting me to be part of this first webinar and for the kind introduction. So we are going to speak about the non-surgical diagnosis of the endometriosis. So if you look all around the world, whatever the healthcare system in 2011, the delay between the onset of the symptoms and the diagnosis of the endometriosis is between 3 to 10 years. And that's true that we have to work in the next future to reduce this delay for the benefit of the patients. So why it doesn't work? Ah, pourquoi ça passe pas les diapos? Diapo passe pas, Louis.
Alors, je sais pas pourquoi ça passe pas là.
Attends, c'est parti. So why this diagnosis is so difficult? I think that one of the main important reasons is that the main problem is that the pain is the cardinal symptoms, and the pain is not synonymous of endometriosis. And the challenge for the gynecologist is to be sure that the pain is really related to the endometriosis and not due to other gynecological conditions or chronic pain syndromes. And the difficulty is due to that you have not a clinical aspect for the endometriosis because of the heterogeneity of the symptoms. So you can have different symptoms. The main symptoms are the pelvic pain, the dysmenorrhea, the chronic pelvic pain, and also the association between these different gynecological symptoms are completely different according to the patient and, as it was previously said, according to the location of the anatomical lesions. And you can have also some patient with bowel or urological signs. And the difficulty is also specifically for the patient with ureteral lesions that you can have, or also for deep lesion in the posterior compartment of the pelvis, some asymptomatic endometriosis. And another problem is that the endometriosis is also associated with numerous painful disease which contribute also to the pain reported by the patient. And specifically, you can see that the risk of fibromyalgia is significantly multiplied by 2 to 3 for the patient with endometriosis, and specifically for the patient with deep endometriosis with an impact on the physical and the mental score. The problem also of the association with the interstitial cystitis, which is multiplied by 3 to 4. And what is very important concerning the clinical management of the patient is the association with irritable bowel syndrome. And you can see that the risk is multiplied by 5, and this risk is also observed whatever the patient present or not an intestinal infiltration. And this is due to the interaction between the nervous system in the pelvis. And if you have some inflammation due to the genital tract, they will have an impact on the bowel and the urological tract. So the impact of a delayed diagnosis, in my opinion, is very important because you will have many impact on the education concerning the work, the social life, the family planning, the quality of life. And that's once to say that there is an impact on the life course trajectory of the patients. The impact is also on the sexuality, and because of the pain and specifically the dyspareunia, you will have a fear avoidance reaction with a lack of desire, a lack of sexual activity due to the patient, for the patients. And if at the beginning the disease is a painful and an infertile disease for the patient, you can see that because of the interaction with the partner, with the people at work, with the society, there is a social dimension with a very important burden for this major disease. So what consequence for the delay of the diagnosis is also the central sensitization. That's once we say the impact of the pelvic pain on the central nervous system. And it was now well known from several years ago that you have alteration of the central nervous system and alteration also of the brain chemistry. And what is more recent in the publication is that central sensitization is also observed for the adolescent patient if the diagnosis is delayed. And one of the consequences of this delayed diagnosis is also the burden for the social and the cost of the disease. And you can see that more the length of the diagnosis is important, you will have a significantly increase in the cost to manage the patients. And for me, this publication is very important, and they compare the patient with an early diagnosis to the patient with a delayed diagnosis. And they consider that the diagnosis was a delayed diagnosis if the longer is more than 5 years. And you can see that if you have more than 5 years to perform the diagnosis, that wants to say that the onset of the symptom arrive earlier if you compare 19 years against 32 years when you have a short diagnosis, and the first physician consultation arrive also earlier. And the conclusion of this paper, and it is very, very important to know that for the management of the adolescent, is that an early onset of the endometriosis-related symptom is the most important risk factors for a long diagnostic delay. And when we look at the delay, you have numerous data who demonstrate that the delay is between 5 to 8 years. But recent publication in 22 and 23 demonstrate clearly that the delay for the diagnosis of the adolescent is significantly more important than for the adults. That wants to say that we must not neglect the dysmenorrhea for the patient less than 20 years old. And now, with the possibility of the imaging process, whatever the transvaginal ultrasonography, which is not always possible for the young patient, but also for the MRI, you can see that it's possible when you have severe dysmenorrhea. In our experience, 300 patients, you can see that for severe dysmenorrhea, for patients less than 20 years old, you observed endometriosis and severe cases of endometriosis, ovarian endometrioma, and or deep endometriosis in 40% of the cases. That wants to say that because of the imaging process, we know now that the adolescent endometriosis is not a myth. It is a completely reality, and it is absolutely not rare. And because also of the imaging possibility, we know that these patients with severe dysmenorrhea, young patients less than 20 years old, can present imaging of adenomyosis. And if you perform correctly the questioning of the patient, you can see that in 2 out of 3 of the patients, the symptoms begin during the adolescence, and the general practitioner, the gynecologist, does not take care of these symptoms during the adolescence. And you see that the earlier the onset of the symptoms, the more severe the endometriosis will be for the patients. And in the other series, recently published 2 years ago, they demonstrate clearly that you have a significant inverse association between the age at onset of the symptoms and the delay of the diagnosis. That wants to say that the delay of the diagnosis decreases with the age at the beginning of the symptoms. So in my opinion, the adolescence of the patient is a key period for the diagnosis of the endometriosis. So the problem is that the main symptoms, as we say, is the dysmenorrhea. But this dysmenorrhea is absolutely not synonymous of systematic endometriosis. So the questioning of the patient are very, very important, very simple, and very cost-effective. And concerning this dysmenorrhea, you have to look at the dysmenorrhea characteristic concerning the age, the duration of the cycle, the severity, as Chloe said, the association with heavy menstrual bleeding. You look at the association to the dysmenorrhea of gastrointestinal or urinary tract symptom, but also deep dyspareunia and nausea, vomiting, specifically for the adolescent patient. And we know that the clinical profile for the adolescent pain and endometriosis is different than the profile presented by the adult. Because for the adolescent, you can have acyclic pain and chronic pain. You need also to have a questioning concerning the childhood exposure. The patient with endometriosis presents significantly low birth weight, significantly for the deep endometriotic patient, the impact on the obstetrical outcome and the breastfeeding. And we know that there is a contribution of the genetic to the occurrence of the endometriosis. And if you have a previous history of the first-degree relatives of endometriosis, that wants to say the mother or the sister, it is a strong argument for the endometriosis, specifically in case of deep endometriosis. But very interesting concerning the adolescent patient is the clinical impact of the dysmenorrhea for these young patients. It's absolutely not normal that the adolescent miss the school during the menstruation. And if you have not satisfactory response to the standard painkillers, and you are obliged to prescribe oral contraceptive pills, not for contraception, but to treat the intense dysmenorrhea, it is strong, very strong argument in favor of endometriosis. And what is recently known also is that the endometriosis is an immunological disease, and you have some immunological profile which are different for the endometriotic and not endometriotic patient, which explain why these patients has significantly more comorbidity, specifically autoimmune disease. You have also depression, you have also the migraine, and in the future, you have problem of cardiovascular disease, mental disease. And all these elements, all these impact of the pain on the quality of life of the patient contribute to the chronic fatigue of these patients. So all these elements are very simple to obtain with a satisfactory questioning of the patients. So it is the reason why in the department we perform a questionnaire, a score that wants to say that we have some parameters which are very simple. You can see that family history, infertility, body mass index, duration of the cycles, and the painful symptoms. And we attribute a score, and we can see that with this score, we are able to classify correctly 85% of the control with a low score as patient without endometriosis. And when the score is more than 25, we classify correctly the patient as endometriotic patient in 84% of the patients. So you have 8 questions and you are able to classify correctly the patient. And you see that more the score is important, more the risk of the endometriosis is real. It was previously detailed by Dabi the importance of the imaging process, and I want not to detail the imaging process because it will be the subject of a next webinar. But now it is well recognized that with the transvaginal ultrasonography or with the MRI, you are able to perform, except for the superficial lesions, the diagnosis of the HOMA and the deep endometriotic lesion. And as it was said by Dabi, the problem of the transvaginal ultrasonography is that it is ultrasonographer dependent, and you must have access to a satisfactory, a high quality ultrasonographer to perform a complete imaging workup of the pelvis. That wants to say that we change the modality of the diagnosis of the endometriosis. And in our opinion, in the department, we consider that with the questioning, it is able to select the patient who are at risk to have an endometriosis. And with the help of the imaging, specifically, the first line is the transvaginal ultrasonography, and second line is the MRI. The place of the transrectal ultrasonography is very limited. You will be able to perform the diagnosis not only of the endometriosis with HOMA and deep endometriosis, but also to precise the cartography, the location of the disease, and what is very important in the management for the pain, for the bleeding, and for the infertility is to know if there is an association with adenomyosis and to precise also the phenotype of the adenomyosis, because the impact of the phenotype of the adenomyosis is not the same on fertility and pain, whatever you have a focal or a diffuse adenomyosis. That's one to say, when I was a young practitioner, we performed a laparoscopic and surgical diagnosis of endometriosis, which was based on the surgical approach and histological proof of the endometriosis. But the patient, they have no cancer. It's not necessary to perform the surgery. And with the questioning, the clinical examination, and the imaging is now in 2026 perfectly possible to perform the diagnosis of the endometriosis. So as Louis said, for us, it is a completely new paradigm for the diagnosis of the endometriosis, a collaboration with the gynecologist and the radiologist to perform a non-surgical diagnosis of the endometriosis. And for me, today, there is no place really to perform a laparoscopy specifically to perform the diagnosis of the endometriosis. But if we look at the results concerning the delay of the diagnosis, we see that 15 years ago, the delay was between 3 and 10 years ago. And the recent review demonstrates 14 years later that in 2025, the diagnosis delay for the endometriosis has not decreased. That wants to say that we have to continue to push in this direction, and perhaps to look, it will be the objective of the next lecture, if the possibility of biomarker will help the practitioner to reduce this delay for the patients. And recently, you have the possibility of the salivary hemiRNA signature for the endometriosis with a preliminary study. It is a preliminary study of 200 patients with a very good sensitivity and specificity. And they published at the end of last year the series of 1,000 patients with exactly the same results. So it is completely preliminary, and we have to see in the future if this type of biomarker or other biomarker will help us to reduce the diagnosis of delay of the endometriosis. And in their proposition, they clearly demonstrate that if you have a radiological diagnosis, specifically which is easy for the HOMA and the deep endometriosis, there is no place to perform a biomarker. The problem of the biomarker will be if you have a normal ultrasonography or an equivocal imaging examination to discuss with or without empirical treatment if it is not efficient to perform the endo test. But what is important is to look at the daily practice. And when we look in our center, which is a referral center, we can see that for the young age patient, less than 25 years old, we recently published that in 40% of the cases, these patients were operated for pelvic pain with a normal ultrasonography in 40% of the cases. And Exacustos, which is a very famous radiologist in Italy, demonstrate exactly the same result, that patients with adolescent and endometriosis in severe dysmenorrhea, you have a normal transvaginal ultrasonography for a well-trained ultrasonographer. And when we look at the evaluation of the endometriosis phenotype in the population, if you look at this large cohort in Scotland, more than 75,000 patients, which diagnostic laparoscopy for chronic pelvic pain, you can see that 56 has endometriosis, and in the majority of the cases, it was superficial lesion. That wants to say that in the large cohort and in the referral center, we don't see the same patients. And when we look at the prevalence of the endometriosis in the adolescent, the recent meta-analysis of HAS ESHRE demonstrates about from 13 studies that in 80% of the patient also, there was stage 1 and stage 2. That wants to say that the majority of the phenotype for the adolescent is patient with superficial endometriosis. That wants to say that with a normal or a subnormal imaging process. And we are preparing with Pietro a paper in this moment. We demonstrate clearly in our patient, in our center, which is a referral center, that wants to say that we have significantly more severe cases. In our center, we have patients with histologically proved isolated superficial endometriosis. So for this patient, it is important to work in the future to improve the diagnosis, because the diagnosis, you have very few publications concerning the radiology and the diagnosis of the superficial lesion. The paper of Leonardi 5 years ago, and the most important one is from Bailey. And you can see that even if you are a well-trained radiologist, you can see that the results of the imaging process, the sensitivity and the specificity are not so good for this patient with pelvic pain and normal ultrasonography. And in the same team in Paris, from Tenon and the American Hospital, they perform a specific paper with a small number of patients, and they demonstrate that with the only patient with isolated superficial peritoneal endometriosis, they obtain exactly the same result than for the global series. That wants to say that we must take care of this result and to know if it is reproducible and if it can help us in the future. So to conclude, I think that with the help of the questioning and the imaging, perhaps in the future, the biomarker, we must absolutely reduce the delay for the diagnosis of the endometriosis, and the diagnosis must be shorter, absolutely non-surgical diagnosis, and you must also perform a phenotypic diagnosis of the endometriosis according to the phenotype of the endometriosis, plus or less associated with adenomyosis. So we need to improve the diagnosis. Why? Because I think if you have an earlier management, you will have, to answer to David, a positive impact on the quality of life, because you will treat the patient and you will treat the pain, and they will be with a better quality of life. You will avoid the central sensitization. Perhaps we will have an evolution on the endometriosis, because we see that, and you have several papers, one from our department and 2 or 3 other recent papers, who demonstrate clearly that before the age of 25, you have a progression of the endometriosis from the superficial to the more severe cases. Perhaps it will help us to have a better management or prevention of infertility or prevention of the fertility. And if we know that this patient has endometriosis, the management of this patient will be specific, because this patient must have association with comorbidity, association with different problems during the menopause, and we must take care of a specific management during all their life. So I think that it is absolutely important to put words to the problem, and for the patient, it is absolutely essential to know whether or not she is suffering from endometriosis. And it is very important, whatever the question, because if the answer is no, the patient has no endometriosis, we have to search for other causes of the pain, and it will be good, and it will reassure the patient and also the family if it is an adolescent. And if the diagnosis is confirmed for the patient, you have to consider the patient as an endometriotic patient for all his life. So I would like to thank you, and we will organize the next year in 2027 in April in Florence, the next meeting of SEUD, and I hope that you will be numerous to participate to this meeting. Thank you very much, Louis.
Thank you very much, Professor Chaperon, for this excellent presentation, who recap all the question about the early diagnosis. And we all understand that the early diagnosis of endometriosis is really crucial to limit the impact of the pain and to improve also the disease management, including infertility and fertility preservation. And we understand that we have to address the specific challenge faced by adolescents. But however, there is a question about the risk about the overall diagnosis that you talk about, and we must also to consider the essential dysmenorrhea and all the other differential diagnoses, not to stigmatize young women in endometriosis when they are no impacted by the disease. And this is precisely why the search for the specific biomarker is so important to clear the situation about women with imaging who is not so clear-cut about the diagnosis about the endometriosis. And we now will move to the next speaker, and I would like to thank Dr. Dorido from the Institut Cochin for taking on this critical topic today about the biomarker. Thank you very much, Ludivine.
You're welcome. Thank you very much for the invitation and for the organization as well. So hello everyone. So I'm gonna talk about biomarkers, and as we said, as Professor Chaperon said very well, it would be very useful to be able to have access to biomarkers to diagnose endometriosis. So it will also help for the lack of access to expertise, imaging, interpretation, and things like that. And so I'm gonna talk about current and emerging biomarkers. And it was talked a lot about endometriosis and the fact that it's a major public health concern because it has a strong impact on the quality of life of the patient, and for the society as well as for the patient, it can be an economic burden. And the diagnostic, it is recognized in 2 countries that decided to invest to help with the disease, which is France and Australia. So we can be proud of that as French citizens. And so, as it was said, so you all heard different numbers for the diagnostic delay from less than 1 year to more than 10 years. And so I used quite recent numbers estimated in between 7 to 10 years in France. And when we look at this diagnostic delay, we can ask why is it that long and when biomarker test could be used. And the issue is that it's not that easy because there is several parts within this diagnostic delay. So there is the fact that the patient themselves don't necessarily go to the primary care for, oh, sorry, I need to put the, sorry, just a second, because this is gonna, okay, sorry. So yeah, so first there is a small diagnostic delay because the patient doesn't necessarily go to the primary care physician right away when the symptoms appear. And then there is usually the need to see several physicians to get a referral to an expert center, or at least someone who is well versed in endometriosis care. And then there is also a delay to get the analysis done and get the imaging analysis well interpreted and the final diagnosis. So with that in mind, we can see that there is a lot of things in addition to biomarkers that can be done. And basically, the idea is that a biomarker will be probably given to a patient when there is already a suspicion of endometriosis. And if the patient goes to a physician that doesn't really believe in the endometriosis or doesn't know about it, it's unlikely that they will get a prescription for a biomarker diagnostic test. So with that in mind, I think we need to be aware that there is a lot of other part where we can help to reduce the diagnostic delay. But of course, today I'm going to talk about biomarkers. So when we looked also at the and yeah, this is to reinforce that there is a lot of studies showing globally the same thing, that there is a part that is due to the patient themselves going to find, trying to find an answer to their pain, and then there is a physician delay, And there is also a systematic delay, and probably the fact that the healthcare system is not very well organized, or at least wasn't, was participating in that. When we try to understand what are the factors that influence the diagnostic delay, we can see that severe dysmenorrhea before diagnosis is associated with an increase. So there is 2 independent studies showing the same thing, that the symptom severity, when you would think that it can help making the diagnosis, is actually associated with a longer diagnostic delay. So it may be because there is like a strong dismission of the pain or things like that, but it's quite concerning, and we really need to emphasize that endometriosis is not just a small pain. For a lot of women, it's very severe pain, and it was said a lot during the previous presentation. So we are aware of it, but we need to have the word out a little more. And quite recently, it was also shown in this study and others that a long diagnostic delay is associated with poorer outcomes in terms of quality of life, symptoms severity, for the fertility impact, and for the psychological stress. So it's very, very important to try to reduce this delay. And is it improving the diagnostic delay? There is a tendency. So this is very broad, 10 years by 10 years. And you can see that it goes from 10 years diagnostic delay to closer to 6 years. So it is improving, and we are in France, we had the care pathways that were established over the last few years. And so we can hope that it's also already improving things. So why don't we have usable biomarkers yet? And I want to emphasize, it's not because we didn't try, but it's also because we tried, but like the scientific community tried, but didn't find biomarkers that were usable. And when I say usable, it means that they need to perform well. And how do we evaluate the performance? It was a little talked about the specificity and the sensitivity, but I want to emphasize what is both these terms. So the specificity is the capacity to detect a maximum of patient, and so to have a minimum of false negative. And the sensitivity is the capacity to detect only affected patient, so to have a minimum of false positive. And what you want for both factors are not the same depending on what the decision you will make afterwards. If the decision is, should I prescribe a contraceptive pill, I think you can tolerate to have a few false negative, and it's not going to be an issue. If you want to decide if you need to do the surgery, then you need to have a very, very high specificity, because of course you don't want to perform surgery if it's not necessary. So we need to keep that in mind. And one way to look also at the data is what is called a ROC curve, or an area under the curve curve. And I don't have the time to go too much into the details, but basically the closest to 1, the better. And that's also a way to identify, to evaluate the performance of a diagnostic test, and one that is based on a biomarker, for example. And I want also to emphasize that, of course, it will be influenced by the prevalence in the studied population, because the fact that you have a positive test is by chance higher if there is more affected patient in your population. So that was to put everything on. I hope I was clear about that. And so, as I said, it's not for a lack of trying that we didn't find usable biomarker yet. And in 2015-16, there was 3 systematic reviews of the scientific literature that looked at everything that was done in blood, endometrium, and urinary to look for biomarker for endometriosis. And there was, as you can see here, there was a lot of studies, implicated a lot of patients, a lot of evaluated biomarkers, and they try to do meta-analysis, so to pool all the data together to have stronger signal and to evaluate more precisely the results. And sorry, it's in French. And the conclusion of this first meta-analysis on blood biomarkers showed that the specificity and the sensitivity was not enough to be useful for clinical practice. And it was basically the same for the endometrial oh, it's not the right presentation, I think. Sorry. It was the same for the endometrial and urinary biomarkers. So basically, there was a lot of work done, but the conclusion was that most of the studies were of the quality, the methodological quality of the studies were insufficient. So we need to do better. Easy to say, but we are going to try. And so we performed another review of the literature quite recently, where we looked differently with the idea that a biomarker that is important for endometriosis should be found maybe in different biological compartments because it's a systemic disease. And so the different compartment, like the blood, which is circulating, the endometrium or other biological compartment could be impacted. And so we looked for papers that were looking for biomarkers, and we looked at what were the characteristics that were taken into account when they analyzed the data. So we chose to only look at paper where there was a description of the endometriosis subtypes, and then we looked if they stratified by endometriosis subtype, and we looked at if they took into account the cycle phase, because we know that it's related to the menstrual cycle, the disease. We looked at if the treatment were indicated and if there was information on the symptoms, rather than just two groups of with and without endometriosis. And so we were able to identify 1,107 biomarkers of interest that were found as significantly expressed in one biological compartment. And as you can see, most of the biomarkers were from the peripheral blood. And then the second biological compartment that was studied was the eutopic endometrium, so usually by biopsies. And there was also peritoneum and peritoneal fluids that are usually obtained during surgery. And what we could already see is that when we look at the information that was collected or described in the papers, less than half were taking into account the cycle phase, the treatment, or the symptoms, which can be, so we can improve on that. And when the information was available, there was even less where they were able to stratify it. So sometimes it's because they chose to only look at one cycle phase, so they couldn't stratify, and for the treatment, it's usually they couldn't do it because they only took patients without hormonal treatment, for example. And when there were several endometriosis subtypes, sometimes they were able to stratify, but not always. Okay. And so basically what we were able to see is that while there was a lot of biomarkers that were assessed, very few of them were shared or found by independent teams in different biological departments. So it allowed us to identify a few biomarkers that we think are a little more interesting than others. They are indicated here, and they were found in, for example, in 4 biological compartments. And we also only took into account the cohorts where there was at least 30 patients, because sometimes there is a lot of studies with very limited number of patients, and so the generalization may not be always accurate. And so what now? So the idea that we will find one biomarkers is quite low, I would suggest. And so what the field is going towards is a combination of biomarkers. And then there is a question on how many and which one and in which compartment. And so we heard about the saliva, we heard about the blood, for the blood. I think there was a lot of trial and it didn't really pan out. So I'm gonna talk about 3 examples. And yeah, of course, to nowadays, we can indeed use the power of artificial intelligence or machine learning to try to prioritize which biomarker are of the highest interest. And so we moved from a targeted approach, like we have a theory that this specific protein or this specific gene is involved. We test the hypothesis, we measure, and we try to validate. And now we use a no a priori approach where we generate a lot of data, and it's usually through omics approach that generate a lot of data, and then we try to find patterns that allow us to have a hypothesis, and then we have a theory that this profile is associated with the disease, for example. And artificial intelligence algorithms are very good at finding patterns. The issue is that they find patterns, but is those patterns relevant or not? It's not always so easy to confirm. And so basically, the idea to obtain good models to do prediction is that we need to have good, reliable data. And that's probably one of the issues that we have in a lot of fields, that the data we have access to are good for very few people or very bad for a lot of people. And so that's the difficulties that we have in defining a new model to predict if the endometriosis is here or not, for example. And so I'm going to introduce very quickly what is supervised machine learning, the principle. And so usually you take a patient for which you know that they have endometriosis or not. So this is labeled observation. You take a part of this data to train a model that the algorithm is going to define. And so you get the prediction model, and then you test this prediction model on a test set. So data that were not seen during the construction to do the evaluation. And this is very important because, as I said, the algorithm is very good to find patterns. And if you give him all the observation, it's going to find a very good patterns, but that is not very generalizable. So the idea is to find a model that is complex enough, but that will apply to a broader population. And that's the issue with the overfitting. So the overfitting notion is that if you give all the data to your algorithm, it's going to find a very complicated model that fit perfectly to your data, but that are not going to work on a broader population. So this is one way to represent it. You will have a model that is fit to your data and not to the global problem. And so you want to find the sweet spot where you minimize the number of errors in your training data sets, so the data you give the model to build, and that will also minimize the number of errors on the independent test data sets. And so there was several approaches using these AI tools to try to identify signature for endometriosis. So there is the use of mRNA data. So mRNA or small RNA that regulate messenger RNA, and their expression is tissue dependent. So it will not be the same in the saliva and in the endometrium, for example. And so there was a lot of trial on the blood mRNA, and there was one meta-analysis recently trying to combine 32 such studies for endometriosis. And globally, what they found is that you don't find very reproducible results. And you even find results that are opposite if you take the serum or the plasma. So it indicates that probably the mRNA are not very stable, and it's more dependent on the population you are studying than on the endometriosis themselves. So next, there was on the same population. I mean, one of these 32 studies was one done where they studied the blood and the saliva. And in the saliva, they described a signature with 109 mRNA. it's quite a costly method to sequence all the RNA, and mRNA are a small part of the whole RNA. And within this signature, they identified 7 that were differentially expressed between the two groups. So only a small part, but still the other mRNA can bring additional signals that allow to have a better specificity. So it was an interesting approach because it included only symptomatic women, which is interesting because, of course, on asymptomatic women, it's not exactly the same questions that we want to ask. Maybe the question will be more about fertility rather than really diagnosis endometriosis. Unfortunately, there is no available data on reproducibility of the saliva mRNA measurement. So all the data are consistent across different measurements, and how is the quality of the mRNA within the saliva is quite unknown. The signature was established in high prevalence settings, so we just need to be aware of it, and so it can be applied to such population, but not to the general population yet. And so far, there is no independent evaluation. So we will see how it goes, and maybe it can be interesting to avoid some surgery the way it was defined at the beginning. And but we need to be aware that even if we get a negative test, then we don't do the surgery, but the patient is still symptomatic, so we need to find why. And so there is also a pathway to be defined for patient with a negative test. And another study that was using the same approach focused on blood proteins. And in their approach, they first validated that the proteins they were measuring were very consistently detected by the method. And then they tried to confirm, they identified a signature for 10 proteins. It's a mass spectrometry, the method that is used to detect these proteins in the blood. And so it's kind of inexpensive and widely used. They included symptomatic and non-symptomatic women, and a quite large number of women, I mean. The technical reproducibility was a requirement, so that's good. The signature was also established in high prevalence settings, so we need to be aware of that as well. And there is also no independent evaluation yet. And in this with this signature, they assess the performance depending on the stage of endometriosis. And it was way less performant for stage 1 and 2, which is probably the one for which we need a good test. So it's still a work in progress, but it's promising. So the clinical use is to be explored, and I think it's ongoing. And there is a very, very recent paper published this month, like 2 weeks ago, I think, where they look at the endometrium transcriptome signature. They use also neural network as artificial intelligence algorithm to identify the signature. And they identified an 11 gene signature. So it was identified through a very expensive single-cell transcriptomic analysis. But the idea is that then you can find this 11 gene signature more specifically. It was also a different approach that included a reasonable number of women. It is unclear to me so far if it was symptomatic or not. I didn't find, I just went through the paper quite rapidly, so maybe it's indicated, but I didn't find the information right away. They had 60 patients, of which 35 were affected by endometriosis. And they identified a signature that is in relevant tissues, endometrium, which we know is probably the origin of the disease. And it was the signature was identified even in specific cells within this endometrium. And so they were able to identify differentially expressed gene, and they were a lot if they took all the patients, and they have subsets if they look at specifically mild endometriosis or severe endometriosis. There is also no validation yet because it's very recent, but for us it's very interesting because it could be evaluated in the menstrual blood within our own project. We could look if we find the same signature. So this is to be done. Yep. And so for the clinical use, this will need to be explored as well. And here here is my conclusion. So it's a difficult quest that need a rigorous research, and we need to precise the questions that we want to answer exactly. So when do we want to confirm endometriosis? And I think it's not gonna be the same test or the same strategy if we want to go very early, like in adolescence, which I think it's very important to focus on that. Or if we want to ask the question, do we need to do a surgery to relieve the symptoms and to cure endometriosis, hopefully. It's not gonna be the same because it's not the same spot during the journey of the patient. The question is, are we gonna be able to have one test for all the patient? And I think it's maybe unlikely. The data seems to, the accuracy seems to differ depending on the different subtype of patient. And usually in the clinical settings, the concurrent condition are often not included. And we really need to take into account if there is other concurrent conditions such as adenomyosis, PMOS or IBS. And why is it necessary to continue in this difficult quest? We need to be able to use it to adapt the care. So for now, it's theoretically because we don't really adapt the care because we don't have a test and we don't have a test that predict outcomes. But this type of test could be used to predict outcomes, the medical response to a specific hormonal treatment, the recurrence risk for after a surgical treatment. And of course, in relation to infertility, it will be very useful to identify the 20 to 30% of women with endometriosis that will suffer from infertility. And if we can identify them earlier, we could propose fertility preservation, for example. And it could also be very useful to prevent the comorbidities, the pain centralization, the anxiety, depression, societal isolation or work difficulties that goes with a long journey. And I would like to thank all the people I work with within the endometriosis group at Institut Cochin, and I put in red the people that are particularly involved in the studies that we are conducting on menstrual blood for biomarker research. Thank you very much for your attention.
Thank you very much, Ludivine. So we arrived to the end of this webinar, and for this first edition, we would like to sincerely thank all the speakers for accepting to participate to this webinar. And we hope that together we are launching a new cycle of regular meeting driven by the FHU. I don't know if there is any question for the speakers specifically, but we are on time because we are supposed to close at 7 p.m. If there is no question, because you can open the mic and ask your question, but if there are no question, I give you rendezvous for the next webinar, who will be the 9th of September, and will be dedicated to imaging and for endometriosis. So thank you very much to everybody. Again, thank you for the speakers for their exceptional quality of the presentation and the very high scientific level. And we hope to see you soon in the next episode.
Thank you.